Good morning. Welcome to the Orlando GI Journal Club for December. I hope everyone's having a good week. We'll be reviewing some interesting studies published this month. So our first study is published in the Red Journal, and it's looking at cap-assisted versus conventional endoscopic technique for the management of food bolus impaction in the esophagus. So food bolus impaction is one of the most common endoscopic emergencies in gastroenterology. And there are two main techniques, either the push technique, where the food bolus is gently pushed down into the stomach with the tip of the endoscope, or the pull technique, where the food bolus is pulled approximately up the esophagus for removal. Cap-assisted technique involves the use of a cap to engage food bolus and provide powerful suction to remove the entire bolus en bloc, and has been shown in a retrospective study to have a higher technical success rate, shorter procedural duration, and fewer complications compared with conventional techniques. And the aim of this randomized trial was to compare clinical outcomes between conventional extraction and cap-assisted technique in removing esophageal foreign body. So this was a randomized trial conducted in 3 centers in Australia. They enrolled any adult patients with suspected esophageal food bolus impaction requiring endoscopic removal. All endoscopies were performed within 8 hours of consent for the study, performed under general anesthesia. The food bolus in all patients was first gently pushed, were attempted to gently to be pushed down into the stomach using the scope tip. And when that failed, the patients were then randomized in a 1-to-1 ratio into one of 2 arms, either into the conventional technique where en bloc or piecemeal extraction was performed using any endoscopic device at the discretion of the endoscopist. So snares, retrieval nets, tripod graspers, biopsy forceps, etc. The cap-assisted technique involved the use of the Olympus 18mm disposable soft oblique transparent cap that was fixed onto the scope tip. The food bolus was first engaged into the cap, constant suction was applied, and then the food bolus was withdrawn from the esophagus. The study allowed patients in the conventional technique to be crossed over to the cap technique after 15 minutes at the discretion of the treating endoscopist. And the primary outcome was technical success rate, which the authors defined as complete removal of food bolus at the end of the procedure without the need for crossover to the alternative technique. So these are the study results. 171 patients were enrolled in a cap-assisted technique, 171 in the conventional technique. And as you can see, the cap-assisted technique was superior in terms of the technical success, removal of food bolus en bloc, the bolus retrieval time, and the total procedure time. So as you can see, in the cap-assisted group, the food bolus was able to be removed successfully in 99% of cases compared to 93.6% of the cases, with p-value of less than 0.001. The rate of en bloc food bolus removal was 93% in the cap-assisted technique compared to just 28% in the conventional technique. The bolus retrieval time was only 4.5 minutes compared to 21 minutes for the conventional technique, and the total procedure time was also shorter in the cap-assisted technique. When you're looking at the crossover to the cap in conventional technique, this happened in 6.4% of cases. Complications rates were relatively low. In the conventional group, mucosal tear was seen in 7.6% of cases, but none in the cap-assisted group. And sore throat was a complaint in 5% in the cap-assisted group, but none in the conventional group. The length of hospital stay was also shorter for cap-assisted at 1 day versus 1.6 days. There was no 30-day mortality. And as you can see, the cost of accessories per case in Australian dollars was just $36.5 for the cap-assisted group, which was basically the cost of the cap versus $115 for the conventional group. The limitation of this study is that the study was conducted at tertiary referral centers, and therefore in all studies conducted in specialized centers, there is some limitation in generalizability of the data. The study included also only patients with food bolus impactions, and therefore the efficiency of cap assist technique in other types of foreign body impaction is unclear. Also, interestingly enough, the size of food bolus was not reported in the study, which obviously is an important factor that affects the duration, the technical success, and the ability to remove the food bolus en bloc. So the cap-assisted technique appears to be more effective and less costly than the conventional technique in the management of esophageal food bolus impaction, and should be the first-line treatment. Our next study is another endoscopic study. It looks at the safety of endoscopic versus radiological gastrostomy tube placement. And this is taken from a large nationwide Veterans Affairs database. And this was again published in the Red Journal. So enteral feeding tube via gastrostomy tube placement is commonly performed and has been used in clinical scenarios to maintain enteral nutrition. Now, there are currently two main ways in which gastrostomy tubes are placed. One, which is placed by gastroenterologists, the percutaneous endoscopic gastrostomy tube placement, or PEG, and G-tube placement by interventional radiology, which we'll call IRG here. Currently, however, there are conflicting data regarding the clinical outcomes and safety between PEG and IR-placed G-tubes. The aim of this study was therefore to analyze the outcomes and adverse events associated with endoscopic and radiological gastrostomy procedures using a nationwide database from the VA. So this was a retrospective study, and these authors used the VA Informatics and Computer Infrastructure Data Repository. And listeners who are not familiar with the Veterans Affairs system, it is a medical system in the United States, which all share a common electronic patient medical record keeping system, and they are spread across 144 medical centers and 1,221 outpatient clinics. And they take care of veterans in the United States. And so these authors were then able to look at US veterans who underwent gastrostomy tube placement from 2011 to 2021. And both inpatient and outpatient data were included. And they looked for specific CPT and ICD codes corresponding to either PEG or IR-placed G-tube. So this is the patient demographics in this study. As you can see, over the period of 10 years, they were able to identify over 23,000 patients who underwent PEGs and 9,715 patients who underwent IR-placed gastrostomy tube. As you can see, patients in the PEG group were older. The mean age was higher at 70.7 years for PEG group and 69.6 years for the radiological placed G-tube group. The comorbidity index was 8.3 in the PEG group, 8.8 in the IR-placed G-tube group. And these were all these associated comorbidities found in these patients undergoing the G-tube placement, and included cardiac disease, dementia, COPD, diabetes, hepatic diseases, renal impairment, cancer, etc. These were the most commonly found indications for gastrostomy tube placement in the study cohort. One of the most common causes were dysphagia following a stroke, 6.8% in PEG group, 5.3% in the IR group. Dementia was another common cause, 10.2% in the PEG group, 10.3% in the IR group. As was malignant neoplasm of the oropharynx, 13.4% in the PEG group and 19.9% in the IR group. These were the unadjusted adverse event rates. So as you can see, the mortality following gastrostomy tube placement was 9.3% in the PEG group compared to 10.3% in the IR group. And they found this difference to be statistically significant with p-value of 0.005. In terms of colon perforation, in terms of colon perforation, the rate was 0.14% in the PEG group and 0.24% in the IR group with p-value of 0.039. Peritonitis was seen in 1.9% in the PEG group and 2.7% in the IR group. Bleeding was seen in 1.6% in the PEG group, 1% in the IR group. And again, the rate of bleeding was deemed to be higher in the PEG group than the IR group. In terms of malfunction and mechanical complication of the D-tube, rates was 6.5% in PEG, 8.9% in the IR group. These authors then adjusted the adverse event rate in terms of comorbidities and then calculated the odds ratio of PEG versus IR. So as you can see, the mortality rate of mortality at 30 days of gastrostomy tube placement was lower for PEG compared to IR, with odds ratio of 0.8 and p-value of less than 0.001. They did find that there was no significant difference in the adjusted odds ratio in mortality at 90 days following gastrostomy. The risk of perforation was also lower in PEG compared to IR with p-value of 0.013, as was the risk of peritonitis. However, they did find that bleeding after gastrostomy was higher with PEG compared to IR with p-value of 0.001. We found no difference between PEG and IR in terms of risk of infection. The limitation of this study is that this is a retrospective study. Because the accuracy of the data that they withdrew from the medical records of these veterans and the VA medical system depends on accuracy in which the procedures are coded. There are possibility that there may be errors in coding, and this would have affected the accuracy of the results and the reliability also. Also, there were lack of medication laboratory data in the study in individual patients at the time of D-tube placement, as well as information on peri-procedural antibiotic use, cessation of anticoagulation, antiplatelet agents, which obviously would have affected the bleeding risk during and after PEG placement or G-tube placement. And also there is no information on the type of G-tube inserted. So in conclusion, in this large nationwide database study, PEG was associated with lower incidence of overall adverse outcomes, mechanical dysfunction, and 30-day mortality compared to IR-placed gastrostomy tubes. Therefore, PEG should be the initial procedure of choice in patients requiring long-term enteral access. Our next study is the comparison of hemostatic powder and standard treatment in the control of active bleeding from upper non-variceal lesions. And this was published by Lau et al. In the Annals of Internal Medicine. Hemospray, also known as TC-325, is a bentonite hemostatic powder with aluminum phyllosilicate clay as the main ingredient, and it forms an adherent barrier at the bleeding on contact with blood. The effectiveness of hemostatic powder, hemospray, as a single endoscopic treatment for acute non-varicose upper GI bleeding is not known. And currently, 2 randomized trials have looked at the efficacy of this hemostatic powder in non-varicose upper GI bleeding. However, the studies were very small, with enrollment of only 20 patients in each of these randomized trials. So the authors aim to compare this hemostatic powder with the conventional approach to managing upper GI bleeding. So these authors conducted a randomized trial involving 3 centers, one in Hong Kong, one in Thailand, one in Singapore. This was a non-inferiority trial. And what this means is that at the offset, they are not looking to see which treatment is superior, hemospray versus conventional therapy. They are only really trying to see if hemospray is non-inferior to conventional therapy. And to perform a non-inferiority trial, a non-inferiority margin needs to be set. And the authors here determined the non-inferiority margin to be 10%. So what this again means is that these authors assumed that the treatment success for conventional therapy would be 90%. And that they then want to show or set their hypothesis that hemospray would be at least 80% effective in being successfully treating non-varicose upper GI bleeding. The study was conducted over a 3-year period, and any adult patient admitted with signs of acute upper GI bleeding and active bleeding from non-varicose upper GI source were randomized in a 1-to-1 ratio to hemospray or standard treatment. In the hemospray group, 1 to 2 bursts of the hemostatic powder was applied to the area of bleeding until no bleeding was observed for 5 minutes. In the standard treatment, standard equipment was used, which means they used contact thermocoagulation using either heater probe or bipolar probe, hemoclips with or without epinephrine injection until cessation of bleeding occurred, or there was flattening of any protuberance or vessel. All patients received a PPI drip for 72 hours post-procedure. And the primary outcome was to look at the control of bleeding within 30 days of randomization, defined as achievement of endoscopic hemostasis during first endoscopy with no recurrence of bleeding reported within 30 days. So 111 patients were randomized to the hemospray group and 113 patients to the standard treatment group. And as you can see, the mean hemoglobin level prior to procedure was 8 in the 8.0 in the hemostatic powder group and 8.4 in the standard treatment group. The common endoscopic findings were peptic ulcer disease, 61% in the hemospray group, 60% in the standard group. Gastrointestinal tumors were found in 26% in the powder group and 11.5% in the standard treatment group. No p-value is shown really in the study to determine the significance. And interestingly, only 9% of patients had spurting hemorrhage, Forest classification 1A, 9 patients, not 9%, and 12 patients in the standard group had the spurting hemorrhage, Forest classification 1A bleeding. And the majority and the rest just had oozing hemorrhage, Forest classification 1B. These are the clinical outcomes at 30 days when looking at the primary outcome of control of bleeding. That again was being able to achieve hemostasis at 30 days. Being able to achieve hemostasis at the first endoscopic procedure with no recurrence of bleeding within 30 days. The treatment success was 90% in the hemostatic powder group compared to 80% in the standard treatment group. When looking at further bleeding in groups, they found that it was 11 patients in the hemostasis group and a total of 21 patients in the standard treatment group had further bleeding. When looking at failed initial endoscopic control, 3 patients in the hemostatic powder group compared to 11 patients in the standard treatment group. And as you can see, the odds ratio favored hemostatic powder with odds ratio of 0.26 with confidence interval of 0.07 to 0.95. When looking at recurrence of bleeding within 30 days, there was no significant difference between the two groups, 9 patients in the hemospray, 10 patients in the standard treatment group. When looking at mortality from any cause at 30 days, there was no significant difference within the two groups with 12.6% or so, with around 12% for both groups. So if you look at the limitation of the study, it is mainly that although this is a randomized trial, the follow-up period is fairly short, 30 days. Also, because the study included all patients with any causes for the non-variceal upper GI bleeding, they comprised patients with a heterogeneous collection of lesions, including 19% of patients with tumor bleeding, and a significantly high proportion of patients with tumor bleeding in the hemospray group versus the standard therapy group. And this may have affected, not our, but the study outcomes and how efficient the hemostatic powder was. Also, because of this relatively large proportion of patients who had tumor bleeding, there obviously means that there is a lower proportion of patients with bleeding from peptic ulcers. And this may have translated to a low rate of Forest 1A bleeding. Endoscopists were not blinded to the study treatment. And also, again, this randomized trial was set in a tertiary referral center, which may have affected generalizability. So the main take-home points are that the TC325 hemospray was non-inferior to standard treatment in patients with non-variceal upper GI bleeding. Therefore, it may be considered as one of the first-line endoscopic treatments in patients with active bleeding from non-variceal upper GI lesions. Our last study is a study from gastroenterology. It looks at the prevalence of PSC in patients with IBD. This is a systematic review and meta-analysis. Up to 50% of patients with inflammatory bowel disease develop at least one extraintestinal manifestation during their lifetime. And the association between IBD and PSC is well recognized. However, there are still some uncertainties regarding the actual magnitude of the degree of association between PSC and IBD, because the current estimated prevalence rates of PSC in IBD patients currently vary widely by up to 10% in some cases. And therefore, the aim of the study was to perform a systematic review and meta-analysis to assess the prevalence of PSC in adult patients with IBD and investigate whether the type of IBD, disease or of disease extent or location, gender and method of diagnosing PSC influence the prevalence rates in patients with IBD. So these authors performed a systematic review and meta-analysis. After database search, they were able to identify 64 studies comprising over 250,000 patients with IBD in 30 countries, with studies conducted in 30 countries. And as you can see, the pooled prevalence of PSC in IBD patients overall was 2.16%. And when you divide up the IBD patients into ulcerative colitis, Crohn's disease, and IBD of uncertain type, the prevalence of PSC is significantly higher in UC than Crohn's disease at 2.47% versus 0.96%. And the authors calculated that the pooled prevalence was significantly higher in ulcerative colitis compared to with Crohn's disease by 1.7 times, with odds ratio of 1.7 and confidence interval of 1.24 to 2.29. Again, they then identified looked at the pooled prevalence of PSC according to the method of diagnosing and identifying PSC in IBD patients and gender. And as you can see, some clear patterns emerge. So if you look at the groups or studies in which the highest prevalence of PSC was identified in IBD patients. This is in studies where PSC was diagnosed by performing both LFTs and ERCP or MRCP. So if you look at the prevalence rates of PSC in IBD patients in studies where LFTs and ERCP or MRCP was performed, the prevalence rate in IBD patients of PSC in IBD patients, 2.9%, 5.1% in UC, and 11% in Crohn's disease. If you look to see if there's been any difference in prevalence of PSC according to gender, as you can see, in IBD patients, the prevalence was 2% in men and 1.79% in women, with a trend towards higher incidence in men than women, although if you look at the odds ratio, it spans 1, and so this is not statistically significant. If you look at, again, ulcerative colitis and then look at Crohn's disease separately, the prevalence appears to be higher in men than women, 2.8% versus 1.7%, and for ulcerative colitis, and 1.3% and 0.76% for Crohn's disease. When looking at the pooled prevalence of PSC, again, according to the extent of disease, we'll first look at ulcerative colitis. So if you look at patients with extensive ulcerative colitis, the prevalence is higher at 5.4% compared to those who had only left-sided ulcerative colitis, where the prevalence is only 0.8%. And if you look at the odds ratio, it's 6.86% with a 95% confidence interval between 3 to 15. And so this appears to show that if you have more extensive ulcerative colitis, the prevalence of PSC will be much higher than if you had just limited disease confined to the left side. When looking at patients with Crohn's disease to see if the PSC prevalence is different according to the extent of disease, as you can see, the highest prevalence is seen in patients with Crohn's disease and colonic involvement, followed by ileocolonic Crohn's disease, 6.8%, and then only 1% prevalence of PSC in patients with just ileal Crohn's disease. And if you look at the odds ratio, is 3.52% for colonic versus ileal, and 3.78 for ileocolonic versus ileal. They then also looked at the prevalence according to the geographical region in which the studies were conducted. And as you can see, the highest rates were seen in studies conducted in South Asia for IBD overall and ulcerative colitis, and then Middle East for Crohn's disease. The limitations of this study is that there is significant heterogeneity among the included studies, with paucity of studies reporting the prevalence of PSC for some geographical regions. There's also some potential overlap of cases between studies looking at national databases and smaller studies conducted but in the same country. And there was also variation in prevalence according to the criteria used to define PSC, which may have affected the pooled estimates. So the main take-home point is that the global prevalence of PSC ranged from 0.96% in Crohn's to 2.5% in ulcerative colitis. Men, patients with extensive UC or Crohn's disease with colonic involvement were more prone to concomitant diagnosis of PSC, and prevalence also varied according to geographical regions and method of PSC diagnosis. And the important point is that this has important implications in establishing a prompt diagnosis, initiating appropriate surveillance in patients with IBD for PSC. So to recap, CAP-assisted technique is more effective and less costly than the conventional approach and should be the first-line treatment for esophageal food bolus impaction. In the large nationwide database study, PEG was associated with lower incidence of overall adverse outcomes, mechanical dysfunction, and 30-day mortality compared to IR-placed G-tubes. Therefore, PEG should be the initial procedure of choice in patients requiring long-term enteral access. TC235 hemospray was non-inferior to standard treatment in patients with non-variceal upper GI bleeding, and therefore it may be considered as one of the first endoscopic treatments in patients with active bleeding from non-variceal upper GI bleeding. Global prevalence of PSC range from 0.96% in Crohn's to 2.5% in ulcerative colitis. Men, patients with extensive UC or Crohn's with colonic involvement were more prone to concomitant diagnosis of PSC, which may have diagnostic and surveillance implications. So thank you so much for joining us this morning. Our next monthly journal club will be on January 5th. 2022. I hope everyone has a wonderful holiday season and Happy New Year. And thank you so much again for joining us, not only today, but during 2021. It really has been wonderful being here with everyone and just sharing some interesting studies. Thank you so much. Please have a wonderful day, week, and the rest of the month. Thank you. Bye.